Dr. Alo, thanks for coming on the podcast.
Yeah, thanks for having me. I appreciate it.
We're both doctors and we're both just trying to help people understand how to reduce cardiovascular risk. First question would be, how do you think about cardiovascular risk? What causes atherosclerosis and how to modify it?
LDL cholesterol is causative of atherosclerosis. So Brian Ferentz said, and his group said, let's just look at every single study that's ever been done on cholesterol. So they ended up with 20 million person years of follow-up. And they found that without question, no matter how you measure it, the higher the LDL cholesterol, the more likely you are to have atherosclerosis, heart attacks, strokes, death, mortality from cardiovascular disease and non-cardiovascular disease. Every study that has been done that lowers LDL cholesterol has definitely proven to have better outcomes than not.
When I see the mainstream analyses, I see that and I think, okay, is it possible that there's another explanation for that we're missing in the name of quote unquote totality of the evidence? And when I look at the details of LDL in connection with cardiovascular disease, what I find is that there are many instances where LDL cholesterol does not associate with cardiovascular disease. Any study in which LDL cholesterol is stratified by a metric that correlates with insulin sensitivity or insulin resistance, you see totally different amounts of correlation between LDL and cardiovascular disease when people are very insulin resistant versus minimally insulin resistant. There are many, many elderly studies in which people who are 80, 85 plus, who have elevated LDL cholesterol tend to live the longest. If you look at the amount of ApoB in a plaque, that doesn't correlate with the amount of ApoB in the serum, suggesting that there's discordance there between ApoB in the serum and ApoB in the plaque. Similarly, if you correct LDL for Lp(a) levels, then LDL corrected for Lp(a) is no longer predictive of cardiovascular disease. It's only when the Lp(a) component of LDL is not accounted for that LDL is connected with cardiovascular disease. And so we run into all of these problems.
The amount of people, if you look at the CDC, that count people as insulin resistant, like pre-diabetic, but not yet diabetic, is probably anywhere from like 15% of the population up to like maybe 38%, let's just say 40.
The percentage of US adults with optimal cardiometabolic health is...
But how did they define that? What is the definition?
Adiposity, blood glucose, blood lipids, blood pressure, and clinical CVD.
Oh, yeah. I mean, if you include all those things, absolutely. That's like the entire country. Paul, that's the entire country. That's literally the whole world's population.
That's what I'm talking about. And let me show this other study. My point is that when the whole country, right, is metabolically unwell, could that confuse us into thinking that LDL is associated or causes cardiovascular disease? I think that we're treating the wrong target. And we know that when people are metabolically unwell, there's a strong correlation between LDL and cardiovascular disease, likely because of increased levels of oxidized LDL and Lp(a). We can't really say that means LDL causes atheroma. The real targets are probably, in my opinion, insulin resistance first and foremost, and then the subsequent increase in the susceptibility of LDL for oxidation and the connected increased cardiovascular risk with Lp(a). And those are very different targets than LDL-C per se. Does that make sense?
There are some trials that have been done to answer this exact question that you're asking. What if we took a bunch of young, healthy people? What if we looked at, subclinical atherosclerosis? It was called the PISA trial. These people had an average age of 45, maybe 46. Only 15% of them were overweight or obese. They found that 45% of people with an LDL of 110, 45% of people had atherosclerosis. If you looked at people with LDL of 130, it went up to 58%. And if you looked at LDL of 150, it was 64% had subclinical atherosclerosis. So that one kind of goes against that.
I think we should be focusing on Lp(a), which is a much better risk factor, oxidized LDL in the arterial wall, and most importantly, insulin sensitivity. So I think that when we are honest about how much of the United States is insulin sensitive, we come to a very different conclusion. But if you stratify the Framingham data by HDL, what you see is a vastly different correlation between LDL and incident cardiovascular disease. If you have a low HDL, the majority of these people are going to have metabolic syndrome. If you stratify the relationship between LDL and cardiovascular disease by any metric that reflects insulin sensitivity, you see this exact pattern, that LDL is no longer correlated with cardiovascular disease.
Well, what you're showing is people have LDL and then you're stratifying it by HDL. Yeah, absolutely. People have a low HDL, have high triglycerides. That's why their HDL looks suppressed, and it even is because they're full of triglycerides. You're picking the worst of the worst. You're picking people who have every human metabolic, insulin resistance.
That's my point.
Smokers, what have you.
When we do any of these stratifications of LDL versus cardiovascular disease by a metric that associates with insulin sensitivity, we see vastly different
But
correlations between
that's not
LDL.
something new.
Wait.
We've known that.
But this is my argument. I think we're not understanding each other here.
No one is disagreeing that insulin resistance is horrible for you.
My point is the opposite of that, which is also this detail that if you do not have insulin resistance, there is essentially no correlation between LDL and cardiovascular disease. If you have some degree of insulin resistance, you are at a higher risk of atherosclerosis, not because of your elevated ApoB, but because of the way those LDL particles, those ApoB particles, are retained in the arterial wall. But that doesn't mean that ApoB or LDL causes atherosclerosis. To me, it indicates that we might be making an error of judgment and that LDL gets wrapped into atherosclerotic plaques that are happening more aggressively because people are not repairing the endothelium because they have some degree of insulin resistance.
Well, it's not the LDL only. I mean, there's a lot more to it. It has to actually be retained. It has to aggregate. It has to get damaged and oxidized and taken up by macrophages. I mean, it's a whole long process. It's not like we just throw an LDL somewhere and suddenly magic happens.
All of these people say LDL causes atherosclerosis. They don't say LDL plus something else causes atherosclerosis.
If you take away that one step, let's say it's LDL plus the the proteoglycans plus cytokines plus whatever inside the arterial wall. But if you take away the LDL, the rest can't do what it's supposed to do. You end the process.
That doesn't mean that LDL causes it. That's a logical fallacy. You can't have fire without wood, but wood doesn't cause a fire. You need a spark. LDL doesn't look like it's enough to incite atherosclerosis. I'm not denying that LDL is correlated with atherosclerosis, especially in the majority of the population that are insulin resistant. But to say that LDL causes atherosclerosis is, in my opinion, false. You cannot corroborate that assertion. I want to show you other studies that you may or may not have seen that will suggest that in humans, linoleic acid and seed oils containing linoleic acid are problematic. If you look at the literature, there's evidence that there's increased LDL oxidation when there's increased seed oils, increased linoleic acids. Oxidation of LDL in the subendothelial space is probably a very bad thing. So in the Jerusalem nutrition study, people that were eating more seed oils had more LDL oxidation. We know that when more linoleic acid is consumed, there's increased LA breakdown products. So there's increased 4-HNE, 9 and 13 HODs. When less linoleic acid is consumed, there's less linoleic acid breakdown products. And we know that when there's more linoleic acid in the LDL particle, that particle is more susceptible to oxidation. Increased saturated fat, the fat that raises LDL, will decrease Lp(a), a very strong risk factor for cardiovascular disease. Decreased saturated fat and increased linoleic acid will increase Lp(a) and will increase oxidized LDL. There's a study in humans showing that soybean oil consumption increases Lp(a)2, is a particle that's associated with LDL that is involved in cleaving oxidized phospholipids in LDL. So that's probably not a good thing if you're increasing Lp(a)2. If you're eating saturated fat from steak or butter, you're going to have more LDL, but you're also going to have less Lp(a) and less oxidized LDL. And if you eat seed oils, you're going to have less LDL. But I think that the cardiology community is missing the fact that you have increased Lp(a) and increased oxidized LDL. Here is a study in humans, decreasing saturated fat and increasing seed oils, increasing linoleic acid, increases oxidized LDL and Lp(a). So I don't think there are any cardiologists out there who would say that increasing oxidized LDL and increasing Lp(a) is a good thing. So it's pretty clear, I think, in humans that when we eat more linoleic acid as more seed oils, we're going to accumulate that linoleic acid in our adipose tissue. That's the only real indicator of how much linoleic acid we've consumed. We're also going to accumulate that linoleic acid in our LDL particles. That LDL enriched in linoleic acid is more likely to be oxidized in the subendothelial space. Wrapping all this back around, when we have LDL in the subintimal space, that LDL that's enriched in linoleic acid because people are eating seed oils is more like a bomb. That LDL is much more likely to become oxidized by the macrophage environment, more likely to become oxidized LDL. One thing that I didn't mention earlier in this podcast that I probably should have is that Brown and Goldstein many years ago clearly showed that macrophages don't take up native LDL in the subendothelial space. They only take up oxidized LDL.
The study that I usually cite, which I feel is the most conclusive, so they had 68,000 participants in this trial. They followed most of them anywhere from 2 to 31.9 years. The endpoints were reached 15,000 times. They had 76,000 fatty acid measurements. Ultimately, the conclusion of this 76,000, biopsy study was that seed oils had a reduction in CV mortality and strokes. Now, we know that consumption of seed oils has gone up. Since the 1960s until now, we've had a 60% reduction in cardiovascular deaths.
If you actually look at the study carefully and you look at the ones that they included, there were very, very few tissue biopsies. So adipose tissue linoleic acid is the only accurate measure of linoleic acid in the human body. And I'll talk about why. Only 2 or 3 of the potentially 30 plus studies looked at adipose tissue linoleic acid. And in those 3 studies, there was no correlation. There was no protective benefit of linoleic acid for cardiovascular disease. You must look at adipose tissue linoleic acid. And as I said, there are studies that shows more linoleic acid in the adipose tissue, worse cardiovascular disease.
How else do you explain the direct line between saturated fat and death? I mean, cardiovascular death.
Where is there a direct line between saturated fat and cardiovascular disease? Wait. A systematic review, meta-analysis of butter consumption.
Butter is different than milk.
Well, butter is full of saturated fat. Meta-analysis of butter consumption, risk of cardiovascular disease, diabetes, and total mortality. Right there. Look at the conclusion.
But Paul
this is a
says
meta-analysis, 9 databases. It's not 9 participants. This is 9 databases, 6.5 million person year. When you say things like saturated fat clearly associated with cardiovascular disease, and I can show you a huge meta-analysis of 6.5 million person years showing that saturated fat in dairy is actually potentially cardioprotective, to me, this says you don't take a step back, you take a step forward, and you look at the details here. I think we have to be better than this for our patients. We have to think about these things and think, okay, there's a lot of conflicting evidence here. What is the quality of each individual study? What have humans done evolutionarily? I think it helps give a framework of what we're talking about, because what we've done evolutionarily is probably something that is reasonably good for humans. People would say, oh, no. But if I look at any free living population of humans, I consistently find massively lower rates of cardiovascular disease and chronic disease and diabetes. They're essentially vanishingly rare. So what are they doing differently than us? They're eating meat. They're eating organs. A lot of them, like the Maasai or the Samburu, they're milking cows. They're eating dairy fat. They're eating honey. They're eating sugar. They're not eating seed oils. That's the thread that I pull on and go, maybe we need to think about these things more carefully. And I would assert that linoleic acid is potentially the worst thing that we could do for our patients. If people are eating animal-based, they're eating animals, they're eating meat, they're eating organs, things we've eaten have historically, you're going to become insulin sensitive. You're going to become more metabolically healthy. You're going to get good nutrients. And we don't need to fear LDL in the setting of metabolic health. And that's my recommendations for people. And I really appreciate you giving me the opportunity to talk about all that.
Again, thanks for having me on.